Yeah. Came in 17. Damn. Give me my money.
Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a young female who presented to our ER with alleged history of drug overdose. Can you begin, sir?
Yes.
A 27-year-old female patient was brought to our ER with alleged history of drug overdose. A little into the past history, she's a known case of bipolar disorder and she's on 3 medications. Trazodone, which is a SARI, which means serotonin antagonist and reuptake inhibitor. Valproate, that's an anti-epileptic, and bupropion, all these medications that she takes. So she had last taken her regular medications 2 days back. So the previous day she had skipped her dose, and on the day
suppose this is not a poison case. If this patient has come to ER for some other reason, what will be the precautions taken from your side? Suppose these patients are on these drugs.
So personal protect.
Any drugs that can interact with this drug.
That is very
Drug
important.
interactions.
Any such drugs,
Drug
antipsychotic drugs, which produces lot of interaction with other drugs. Whenever we start any drug, we have to always check the interactions. Otherwise, suddenly this patient may go to some serious problems like hyperkalemia, hypokalemia, or electrolyte imbalances, arrhythmia. That interactions are very important. So whenever we start any drug on these patients, we have to check the interaction. Otherwise, very rarely this patient can go to drug interaction related problems.
So most of them prone to QTC prolongation also, antipsychotics.
Okay. So our initial 10-second assessment, she was conscious oriented and also obeying to our commands. So we quickly moved on to the primary survey. Airway wise, it appeared patent. There was no hypersalivation, no drooling of saliva. There was no obvious anatomical deformity or any injuries noted over the mouth. Then moving on to the breathing part, she had air entry to be bilaterally equal, which was clear on auscultation, maintaining saturation of 98% in room air with normal respiratory rate of 16 cycles per minute. There was no hyperventilation or hypoventilation noted in this patient, so no respiratory depression or distress.
What are the common respiratory abnormalities you see in poison cases like this?
So if we talk about opioid overdose, then patient will have respiratory depression. Benzodiazepines causes respiratory depression, and certain medications like that, CNS stimulants like cocaine, LSD, amphetamine, these will cause stimulation, so patient can come with panic attack, hyperventilation.
Aspirin?
Aspirin, first it will have hyperventilation, followed by, so respiratory alkalosis first sets in, then because of lactate development, patient goes into metabolic acidosis, and then patient will have respiratory depression if loss
Anything
of...
other than this acid-base balance, anything other than that, we have to suspect.
I didn't get it.
No, you told acid-base balances like this metabolic acidosis, alkalosis, respiratory alkalosis, so many abnormalities can be there. Other than any lung involvement in poison cases or toxicological cases, immediately.
Alveolar hemorrhage.
Diaphragm paralysis.
Alveolar
From
hemorrhage.
paralysis is very rare.
Very rare.
So one common thing is aspiration pneumonia. Second thing is OP poisoning. They develop ARDS. Then the third one is herbicide poison. They can develop lung disease, interstitial lung disease. But that takes longer time. Fibrosis, interstitial fibrosis. Acute problems are mainly in aspiration pneumonia and ARDS in drugs like OP poisoning.
OP poisoning. Okay. So circulation wise, she was tachycardic with a heart rate of about 113 beats per minute with blood pressure of 126/70, and all peripheral pulses were palpable. Extremities were also normal.
Presenting complaint of the patient.
Drug overdoses. She had taken about...
She herself mentioned.
She herself mentioned. Okay. She was conscious oriented and talking to us. The history that we have taken is elicited by the patient herself.
Okay, good.
So she had taken 20 tablets of a regular medication, that is trazodone.
She was taking 3 different drugs.
3 different drugs.
So only trazodone she took 20.
20 tablets.
Other drugs,
2 strips of it,
no
1 strip
of.
containing 10 tablets each. So disability wise, she had a full GCS score of 15/15 and no obvious any neurological weakness that was detected. Plus, she had pupils also were 2.5 millimeters bilaterally reactive. Generally, in drug overdose, pupils have very crucial role to play because some toxidromes patient can present with meiosis and some can present with mydriasis. So that will give an insight on the toxidrome that the patient is presented with. Then exposure wise, patient was had a normal temperature of 98.6 degree Fahrenheit with a GRBS of 106 milligram per deciliter.
Why temperature is important in this patient?
It's like, again, sir, it gives an insight on the toxidromes. Certain drug overdose, like antipsychotics especially, can cause hypothermia, that is neuroleptic malignant syndrome. So this also has to be kept in mind. And certain drugs like benzodiazepine can cause hypothermias. So just like pupils, even body temperature is also important. Then
Taken the history, what medicines she took it, she herself gave.
she herself gave, sir. She is on trazodone 100 mg that she takes once in a year, once in a day in the night, and she's been taking that for about 1 year. And two other drugs that she's been taking since 9 years, that is valproate 300 mg BD and bupropion 150 mg again in the night. So she has been diagnosed with bipolar disorder about 9 years ago. So ever since then, she has been taking two drugs. Only last year, trazodone was added, and that's the drug that she overdosed on. Then moving on to our adjuncts, we did a ABG in this patient. So no acid-base derangement was seen, no hypoxia also noted. Lactate levels, which is important, that is also was normal in this patient. She had a pH of 7.45. PCO2 is 39.4.
7.45 is towards alkalotic side.
Alkalotic.
It is not normal, completely normal. It is towards the alkalotics. Normally, if you take ABG in any of these patients, you don't see. So what do you suspect in somebody having alkalosis like this? What is a CO2 level? What is a O2
So
level?
CO2 level was 30.4. Basically, it was a respiratory alkalosis inching towards it because patient was very tachypnic when she came. Tachypnic meaning she was restless. She had that panic attack when she came in. So in that aspect, it
So
is
which
there.
electrolytes or which mineral you have to see in this condition?
Potassium.
No.
No? Calcium.
Respiratory calcium.
Calcium.
What is the calcium? Is it done?
The calcium was done, so it was normal. 8.9.
Okay, so whenever somebody admit to emergency room with tachypnea because of panic attacks, hypocalcemia can be associated with that. It is only a shift of calcium. Calcium is not lost. How do you treat that condition? Somebody is having tachypnea and his calcium is low. There is a spasm of so how do you treat it?
Actually, we can give a calcium gluconate as
No, that carbon dioxide, that rebreathing thing.
Immediately give a rebreather mask, then calcium gluconate can be given because we have to put an IV line, then only we can give calcium. So give a rebreather mask and give calcium gluconate. Okay.
So in our next thing, adjunct after ABG, we took was an ECG, and this was crucial in order to rule out any arrhythmias because patient was tachycardic even though her heart rate was regular in rhythm upon palpation. So this patient had sinus tachycardia, but there was no QTC prolongation, no significant STT changes or any arrhythmias noted including ectopics. This patient, it was normal, but QTC was not prolonged, but it was lengthier, like it was about 454. So we had to keep an eye,
higher range of the
higher
normal.
range around the normal. So we had to keep an eye. So serial
These drugs are known to produce long QT.
long QTCs.
So what will be the suppose QT is prolonged? What will be the next level of problem?
The patient can go into an arrhythmia, that's torsades. So that is life-threatening with and has to be immediately intervened, and patient has to be given magnesium sulfate 2 grams. So QTC prolongation has to be kept in mind. Patient will have high chances of throwing arrhythmias.
So whenever patient come with this type of drugs like antipsychotic drugs, you have to always look at the QT interval, QTC. What is written in the ECG will be QTC. Okay. And some drugs it reduces, some drugs it increases. Normally, this type of drugs produces long QT, and ultimately they go to Tosadis depointis.
Pointers. So her ECG was normal. So we had checked the ABG, GRBS and ECG. So these were our primary adjuncts that we had used, and nothing else that could indicate any other intervention to be done right away. So we moved on to the secondary survey.
Blood pressure,
Blood pressure was normal, so 126/70.
menstrual history.
Coming to the secondary survey, sir. The events that led up to this is what I stated. She had taken about 20 tablets of trazodone of 100 mg each, and between 9 to 10 p.m. So she presented to our hospital in about 1 hour, 1.5 hour maximum. She was here, and she a little look into her past history. She was diagnosed to have bipolar disorder since about 9 years, and she's also has significant suicidal attempts history in the past. So ever since she was in school aged a girl, she was self-inflicting wounds with her every time she was not in a good mood or any stress. She had self-inflicting wound history. And in 2015, she had overdosed on paracetamol and she had gotten admitted for the same. So this time she presented with a trazodone overdose. So the event that led up to this is she had a depressed mood for about a month, which was not paid much attention to, and which is why she ended up going into deliberate self-harm.
What is the importance of menstrual history in this patient? Sarah's asked, no?
So this patient had last menstrual period was first week of July. Exact date she didn't remember. She was unmarried and her periods were regular with normal flow, and she was not on any OCPs. So in this,
Is there any necessity for doing a pregnancy test?
Yes, sir, it's crucial.
Even if she is unmarried?
Yes, sir.
Okay, one is pregnancy test. Other one?
If she's on.
What is the importance of menstrual history in a female patient, especially who is having suicidal tendencies? There are a lot of mood swings during the menstrual period. Whatever mood disorder they have, they are going to aggravate during the menstrual period. So that type of problems can occur. So we have to take a detailed history. If the patient is having menstrual cycle during that period, then most of the things are induced by that hormonal imbalance. Okay.
So we even did a pregnancy test, sir, and it came back to be negative. In this patient, if at all she ends up dying or anything, it will becomes an MLC case. Then pregnancy test has to be done.
So if is suicide attempt is reportable to police? Or?
It's not, sir.
Okay. According to Indian law, it is not required. But if you think that patient is having impending death or dying patient or already dead, then you have to inform definitely.
Yeah. So then moving on to a little on her personal history. She drinks alcohol but occasionally, and her last drink was about 2 months back, and she does not smoke. So this was her obstetric, past history and personal history. Then in our examination wise, systemic examination was pretty clean, and we also had to note for any external injuries, any forceful assault. All of this has to be seen and documented. If there's any discoloration of the teeth, nail, hair, any pungent odor or specific odor, because certain toxidromes or poisons have a specific or peculiar odor to them. So that has to be noted. And since she's a female, not just female, patient sexual assault also has to be kept in mind, and also any external injuries. But she was. She didn't have any of those, and she was also sexually active too. Then, eye examination is also important for any conjunctival color. Again, pupil dilatation, extraocular muscle movement, all of this has to be checked. And then while we're asking for the history, we should also ask for stool colors, urine output, urine color. All of this also has to be. Any bodily secretions that are abnormal has to be, if not stated by the patient, has to be asked as a leading question to get to know about it.
So what you did for the patient in emergency room?
So sir,
how do you manage this type of poisonous cases or toxicological cases. We don't know whether we can call it as poisonous cases, because poison means something else. This is
Overdose.
drug overdose. So drug overdose cases, how to manage?
So, first of all, we have to know what medications that she's taken, dose, and we have to calculate whether it is above the toxicity levels or not.
So normally it is not possible. You cannot calculate, because they are giving a history. They are telling I have taken 20 tablets. It may not be possible. Sometimes they'll tell 20 tablets. They'll be taking only one tablet. Sometimes they tell only one tablet. They may take 20 tablets. All these things are very difficult. Whenever you see a patient, toxicological symptoms or toxidromes are very, very important. Like snake bite. Snake might have bitten or might not have bitten, or a dry bite or actual bite. You see the symptom, you treat the patient. So how do you treat? So you can calculate. If you know, you can calculate. But that all, you have to send the sample for toxicological analysis for lethal dose. Okay, that you have to see afterwards. But you have to see the symptom at present.
So she presented to us within about an hour. So this gastric decontamination in this patient has a role.
How do you?
So we can either go with gastric lavage or activated charcoal, but before that we have to collect the samples. Vomitus, gastric aspirate, all of the samples we'll have to collect and send for toxicology, including urine and blood samples. So the presenting complaint of the patient was she was dizzy, excessively drowsy, and she had palpitations. Along with this, she was anxious, and she also complained of tingling and numbness in both of her hands. So other than that, there was no other complaints, symptoms. When she came to the ER, here she vomited twice, but no history of any abdominal pain, altered sensorium, altered behavior, or breathing difficulty.
Normal vomiting may not be a problem in a patient who is having this type of drug overdose. But induced vomiting, is it advisable or not advisable?
Induced vomiting previously, now they don't do it.
It is not advisable. What is the problem?
It can cause aspiration.
Aspiration is the most important. Okay, so we should.
Injuries.
So we should never advise to anyone to produce inducing a vomiting this one. And even if there is vomiting, we have to try to avoid that. We have to give some antiemetics and stop it.
So in the negative history, there was no history of any profuse sweating, chest pain, bowel bladder incontinence, loss of consciousness, seizures, visual disturbances, altered behavior, abdominal pain, or any upper GI bleed, excessive salivation, dry skin. All of this has to be kept in mind. She did not have any of that. So
you can put a
RT.
Aspirate.
We first vomitus.
How long you can wait? Till what time you can do all these procedures, aspiration?
About an hour, sir.
Okay, in an hour, if the patient come to hospital, we can do it. Is there any extended protocol for that? Up to some more time, can you do it? Especially when there is a large amount of poison, or if they have taken a extended release tablet. In that conditions, you can go for a prolonged aspiration. Means prolonged means even after 1 or 2 hours, you can try the aspiration of the offending drug. Okay. Otherwise, with less than 1 hour, more than 1 hour, we should not try all these things.
So we collected the vomitus, then we placed an RT, and then we gave activated charcoal in a dose of 1 gram per kg. So to her, we gave 60 grams of activated charcoal. And then, so this was the gastric decontamination part that was done. And apart from this, we had to thoroughly check for any drug interactions.
Any other drugs are available for gastric decontamination?
Except for heavy metals, corrosive agents. Corrosive agents like sulfuric acid, hydrofluoric acid, HCl.
For them, there is no role of only water.
Water.
Acid and alkali, only water. Dilute it, that's all.
Heavy metals also we don't do gastric decontamination, sir. Apart from that, for lithium, then many drugs, all the other drugs, aspirin, paracetamol, all of this, there's a role for gastric decontamination. Only strong acids, alkalis, heavy metals, we don't do it. And alcohol, kerosene, these we don't do. Otherwise, for everything else, there is a role. Then, so apart from this, our next line of management was on the expectant line. So we had to observe the patient for any signs and symptoms, and we had to get to know the adverse effects of trazodone. And also, even though she did not state, we had to keep our eyes open for any co-ingestion of other drugs and also alcohol intakes that she might not have stated. So we put the patient on a continuous cardiac monitoring because trazodone is known to cause serotonin syndrome, and the other thing about trazodone is it has a lot of drug interactions. So any drug that we give could interact with the patient's trazodone, including antiemetic. Ondansetron is first of all high risk for QTC prolongation. So in this patient, something as simple as an ondansetron can push her for QTC prolongation, arrhythmias. So like that, many other drugs are there. So drug interactions had to be checked. Patient was put
If
on.
she vomits, what do you do? Any drug you give, see the interaction, whether they prolong the QT or not, you can see. If nothing is possible, you can give steroids. Steroids can be given in intractable vomitus, and if the patient does not like responding to any treatment, or we are not able to give any other drug, steroids may have a role. So, but that is not a definitive drug like your ondansetron or metoclopramide or cisapride, mosapride. Their actions are different. Okay, but that's a last resort.
So any other antipsychotic drugs if she has taken, again like SSRI, SNRI, again it will push her to serotonin syndrome. So including tramadol, everything has to be like first checked and then given because antipsychotics have a lot of drug interactions like I stated. So apart from this, she was hydrated and put on a continuous cardiac monitoring, and every second hourly until the QTC was like normalized, we took ECGs, and serial ABGs were also taken for at least about 6 hours of her admission time to the ER to rule out any cardiotoxicity, and patient was put on a watchful period to see for any further development of signs and symptoms because there is no specific antidote for
now this
trazodone.
patient is stable, she has not developed any problem. Can we stop all the psychotic drugs now?
At present, it stopped, sir.
During admission, we stop. And after admission, we can slowly restart.
Psychiatric
Once the
counseling.
patient is stabilized, immediately you have to put the patient on antipsychotic because we don't know what was her state before starting the drug. Whether the mental stability is maintained by this type of drugs, we don't know. So immediately once he is stabilized, there is no ECG changes. Immediately after, with the help of psychiatrist, we have to restart the drugs slowly. Not the same drug, some other drug which can be safer than this. Okay.
So, trazodone specifically causes cardiotoxicity and visual disturbances. Ocular toxicity is also there. Apart from this, patient can have altered behavior and very prone to serotonin syndrome. Serotonin syndrome presents with, it's a triad of neuromuscular excitation, autonomic instability wherein patient can have hypothermia, and also altered mental status. So this would be the triad of serotonin syndrome. And there's a Hunter
Hyperthermia.
hyperthermia, sir. And there's a specific diagnostic criteria also called as the Hunter diagnostic scale. So this can be used in order to diagnose serotonin syndrome. It differs from neuroleptic malignant syndrome with pupil change, wherein serotonin syndrome will have dilated pupils and NMS will have meiotic changes. So other than that, presentation wise it's pretty same, wherein patient will present with agitation, restlessness, irritability, profuse sweating, dilated pupils.
What will be the difference in these type of syndrome, serotonin syndrome or neuroleptic malignant syndrome, to tetanus? Tetanus is a close differential diagnosis of these two conditions. What is the major difference? They have autonomic dysfunction, they have rigidity, they have fever, they have pupillary abnormalities. What is the single most important change from tetanus to NMS? There is altered mental status. Tetanus patient till the end, patient is fully conscious oriented. They'll understand what is the problem. Whereas here, patient is having altered behavior.
Altered sensory.
So tetanus is a close differential diagnosis of drug-induced rigidity.
So that will be about serotonin syndrome.
If the
And
patient develops fever, how do you manage in this type of syndromes?
dantrolene, bromocriptine,
Ideal drug is dantrolene.
dantrolene.
Paracetamol can be given. Dantrolene, if it is available, you can give. Bromocriptine is available everywhere. That is a thing we use routinely. Dantrolene is available in anesthesia area. If it is available, that is a very safe drug.
Then antidote for serotonin syndrome will be cyproheptadine. Cyproheptadine.
Where else cyproheptadine used? Is it available in the market? Cyproheptadine is an anti-migraine drug, and it is also used in appetite. Okay, it is available as syrups, cyproheptadine syrups. It's available in Indian market.
Commercial name, sir.
Commercial
Oraxin.
So it is available. So only thing is continuously if you give for some patients, LFT has to be monitored. 1 or 2 doses you can give easily. Cyproheptadine is a treatment for most of the drug-induced this type of movement disorders.
So there is no specific antidote for trazodone as such. So it is mostly the line of management will be expectant and preventive. So then psychiatric counseling was also placed, and there is something called as a sad person score, which has to be basically it's a score wherein we check in for patients to get an insight on the likelihood of the patient attempting suicide, like how depressed are they or what is their mental state that they can go to take an extreme action like this. So that's available in where? Medscape. Medscape.
The scoring system. Calculator is available.
So this sad person score, S is for sex, and males are more predilected to commit suicide. Age less than 19 and more than 45 years. P stands for previous attempts. And then E is for any excessive alcohol or drug intake. R is rational thinking loss. PERS. Again, S stands for any suicidal attempts. Then if the patient is separated, divorced, widowed. O is for if the patient has an organized thinking on how the patient is going to commit suicide. In what way, whether it's going to be like drowning and all that, if the patient makes up a plan. Then N is no social support, and S is stating out suicidal attempt loud, like I'm going to commit suicide and all that. So out of this, depression, rational thinking loss, organized plan, and stated intent holds 2 score. Rest all is 1. So this higher the score, higher the likelihood that the patient is going to commit suicide. So this will also give an idea on whether the patient can be discharged safely home or will have to be admitted for observation.
Counseling.
Counseling.
And, if needed, newer antipsychotic drugs other than what she tried.
So this patient was given sad person score. We had anyway kept her for observation, sir, but it was lower on the side, so we could discharge her because she had adequate social support. Her parents were there. She had her friends around with her. So with this strong social support, we discharged her. Her stay in the hospital was pretty uneventful. So after about 24 to 48 hours of observation, we discharged her.
Along with that, actually, along with this, if a patient coming with a suicidal intention, after the initial management, we have to create a rapport with the patient. One thing is actually to assess the suicidal intent, like is she planning for any further attempts like this, and also is she currently stable enough to be discharged and all that. So we can assess in 3 areas. One is the patient is having a non-mental disorder, and also is she having any family or an interpersonal relationship disorder, or she's otherwise okay in the current state. So if she's actually over the course of time she's actually better right now with no other mental disturbances right now, we can actually discharge her with some advice regarding self advice, like how to seek help when she is in acute distress, or also like give her some phone numbers or something, and you can discharge the patient. But if she's actually in a state whether she's even if she goes home, she's having family issues and all that, we can arrange the help of some social worker or someone to like help her through get through that. But if she is a non-case of psychiatric disorder who came with a suicidal attempt, then we have to definitely give her some psychiatric consultation. We might require medications for further management. So these are the three tiers which we through which we can dispose the patient who is coming with a suicidal intent. And also the patient coming with toxicology, this thing. Our primary this thing will be we go through a primary survey, assess the hemodynamic status and all. We give the conservative management. Then according to the symptoms, we can manage the patient. So within 1 hour, we as we discussed, there are three pathways. One is actually orogastric lavage, which we can give within 1 hour. We're putting a large bore tube. Actually, it's preferably we go for a eval tube. It's an orange colored tube which has got a bit more wide about 24 to 26 gauge.
It's an
Actual thing which
tube.
we have to use for
It's not
this kind of
rice
this thing. And initially, we suck some fluid which we send for toxicology analysis, and then we give a bolus of about 500 to 1 liter of saline into the gastric, and then we aspirate, so that whatever we can get through the tube we aspirate, and then we keep an RT open through a collection bag, so that anything aspiration is coming up which we can collect. So the only main contraindications are corrosive agents. It could be alkali or acidic, which should be contraindicated. And also, if the patient is having excessive vomiting and all that, better we avoid than putting too much force into putting the tube. Second will be activated charcoal. The dose will be preferably 1 gram per kilogram, or you can even go for just a basic 50 gram. We can give. We can actually take a small tray and mix it as a slurry, and which we can pass through the same tube. And just keep it in the this thing, so it will pass through the motion along with the this. It basically it adheres to whichever toxin is in the stomach, and it will pass through the stools. In pediatric also the dose is same, only 1 gram per kilogram, which we can use as toxicology. Third will be this PEG, or like polyethylene glycol, which we can use in case of heavy metal poisoning, like too much of iron overdose, or even in this thing. High-risk diltiazem or verapamil poisoning, like Coccinella blocker poisoning also, we can give PEG, which is actually a cathartic agent, which can induce like loose motion. You can empty the whole bowel irrigation, which is helpful in this kind of poisonings. These are three pathways which we can use in a patient who is acutely coming to the hospital with acute toxic overdose or injection. And there are like actually some next level or enhanced elimination. One is urinary alkalization, which we can actually induce to further eliminate the toxin, and second will be extracorporeal removal, which will be using the help of dialysis. Along with that, we have certain filters available through which we pass the blood, which can again remove some of the toxins.
Charcoal chemoperfusion also available.
So there are even along with the dialysis, we whether a CRT or even a normal dialysis, we can attach certain filters like oxidase and all that, which can actually filter certain toxins which cannot be like neutralized by any other antidote. So these are the other options available. And also at any point we have to monitor the hemodynamic status, airway, any possible airway compromise, and also any development of arrhythmias or anything. Especially antipsychotic patients, we always have to look for the QTC, which can again for go into toxicity points and all that. So this will be the basic management of a case coming with toxic overdose.
Regarding the patient is already having drugs which can produce serotonin syndrome. So from our emergency management, we have to avoid certain drugs. One is Hornden syndrome, and number 2 is the metoclopramide. So that is also not recommended. And with regard to analgesia, what are the best drugs?
Paracetamol.
See, all opioids will worsen this one. Morphine is a better choice, but pethidine will cause more adrenaline release, and it will precipitate serotonin syndrome also. Next one is fentanyl. So we can give safely fentanyl. And regarding the induction agent ketamine, that will again produce adrenaline. So tachycardia. So this may worsen the arrhythmias or hypertension or all these things. We have to keep in mind. Then adrenaline usage. For example, if a patient is having congenital injury or local infiltration, you want to go, you should avoid the adrenaline. And there is a swing in the autonomic imbalance, whether the patient may go sometimes hypertension or orthostatic hypotension also. So when the persistent hypotension, norepinephrine is not advisable. Direct acting vasopressin is a drug they are recommending. So these are all certain things you keep in mind.
Okay, sir.
Thank you, sir.
Thank you.